Hello, everybody, and welcome. I'm Shelley Gunther, sonographer and clinical marketing manager here at Clarus. We're so pleased you joined us for today's live webinar titled POCUS Skills for Your Next ED Shift, 5 Ways to Elevate Patient Care. The tag team of emergency physicians, Dr. Frenkel and Dr. Brian Johnson, will join us in a moment in what promises to be a highly dynamic and content-packed educational session. And today we're showcasing the FDA cleared and now approved for sale in the EU and Australia, Clarus PAL HD3, our newest wireless high definition scanner that uses both a phased and linear array on one single head. Now you're among just over 3,100 acute care and outpatient clinicians who registered for today's popular session. You're about to see examples of a variety of ultrasound exams that these doctors perform in their hospitals, studies that expand the use of ultrasound beyond the EFAST exam. And following the main presentation, sonographer and newest addition to our webinar team, Janae Smith, will be performing live POCUS scanning using the Clarus PAL. And she's going to show you how versatile the PAL actually is. Now, at any time during today's webinar, please don't hesitate to use the Q&A box to ask your questions, and Dr. Frenkel and Dr. Johnson will address them in the live Q&A session following the presentation. Now, I'll be hosting today's event, and I'd like to begin by sharing a few papers on the topics we'll be covering today. Now, in this first article, the authors wanted to review the sensitivity and specificity of ultrasound exams performed by emergency physicians in patients suspected to have SBO, or small bowel obstruction. And indeed, several studies showed that point-of-care ultrasound can be used as an optimal option for the diagnosis and early management of small bowel obstruction, and suggested that POCUS has a high sensitivity in detecting dilated loops of bowel, leading to the diagnosis of SBO. Now, the goal of this next one, it's a review from the Journal of Emergency Medicine from 2021, and it's to provide the emergency physician with succinct and up-to-date information and instruction regarding the current uses of POCUS for patients presenting with particular ocular emergencies. Ocular pathologies that are common or for which ultrasound is particularly useful are discussed here, with the conclusion that ocular POCUS is a very useful tool in the evaluation of trauma, including vitreous hemorrhage and retinal detachments, as we'll see today. And finally, this review from the Canadian Journal of Emergency Medicine studies the common presentation of hip fractures to emerge departments and how the associated pain can be managed with a femoral nerve block and avoid the sedation and delirium associated with opioids. There's also evidence that shows that with opioids for pain control, there's an increase in the incidence of adverse outcomes, which really highlights the need for alternative methods of pain management in elderly patients suffering from hip fractures. And we'll see how Dr. Johnson performs this ultrasound-guided block in the presentation. Great. And so just before we begin, I'd like to put up a poll. It'll help us get a better understanding of where everyone's at with regards to using ultrasound. And we'd like to know, what types of ultrasound exams are you performing today? Are you just doing fast EFAST rush exams? You can click all that apply here. And we'll give this just a couple of seconds. 3, 2, 1. Great. So yeah, just as I kind of figured, most are performing just kind of the bread and butter fast and rushed exams, some nerve blocks and peripheral IV. And there's a few of you that don't do any ultrasound, so we hope that we can get you on board today. Great. So I'm happy to introduce you to our guest speakers today. Dr. Brian Johnson is an emergency medicine specialist joining us from just across the border in Renton, Washington. He earned his medical degree from Emory University School of Medicine and specializes in family medicine, emerge medicine, and hospital medicine. Following completion of his residency, he completed ultrasound fellowship and is a huge advocate for POCUS today. And Dr. Frenkel completed his MS and MD at the U of California Joint Medical Program at Berkeley and San Francisco, and is also fellowship trained in POCUS. He practices here in Vancouver, where he continues to spread the word about POCUS across the province and in rural and remote communities. And we're fortunate to have him as our medical advisor here at Clarus. Gentlemen, I will hand the presentation over to you.
Thanks, Shelley.
Hello, good to be here. Thanks for having me. So me and Oran are going to do 5 ways to elevate patient care using POCUS. And so we're going to kind of go back and forth on these 5 topics. So I'll start, but it's a pleasure to be here. Okay, so the outline, we're doing 5 topics: ocular, appendicitis, peripheral IV placement, SBO, and then finally the femoral or fascia iliaca nerve block. So I'm going to kick it off with ocular. When should you do this? Person comes to the ER with painless vision loss to one eye, or even flashes or floaters. That's when you're going to want to do an ocular ultrasound. And briefly, anatomy. So really, we're looking at the back of the eye here, guys, the back of the eye. We're not going to look at the anterior chamber or lens today. We're going to talk about vitreous, retina, and optic nerve. Those are the 3 things we're going to identify in ultrasound. So when you put your ultrasound probe on the eye, this is what normal is, kind of my screen right. So you will see the anterior chamber. Then you'll see this large kind of, hopefully kind of black vitreous. You won't even see the retina because it'll be nicely tethered to the back, and then you'll see that optic nerve. So this is normal. And then how do we do this? So we put the patient at 45 degrees. You put a clear adhesive dressing over the affected eye, and then remove all air, because air is the enemy of ultrasound. And then you kind of put some sterile gel onto the clear adhesive dressing.
I'm going to chime in, Brian.
Yeah.
Some people talk about putting gel directly on the eye and they just like squeegee it out of the bottle. And I'm going to make a hard no to that. Like, if that's my eye, I don't know where that gel's been. I do not want it in my eyeball. Please put the protective dressing over my eye. Thank you.
Sarah, you are correct. There are those out there who believe that they should just put the sterile gel onto the eye itself. And I just think that's just a mess. It's just a recipe for disaster. The beauty of this is you just take it off when you're done, and the eye is pristine. So yeah, totally agree. Debunk that, like just putting the goo right under the eyeball. It's just it's not a good thing. It's not good for anybody involved. It's gross. It's nasty. Just tegaderm it, and then the stuff over the top. So it's the only way to do an ocular ultrasound. The only way.
There you go. The only way.
The only way. The only way. North of the border, south of the border. That's what we do. Same thing. All right. Yeah. So once you have that on, have the patient kind of move their eye left and right. Have them look up and down, because you want to do this what's kind of called kinetic echography. You want to see dynamic movements of that eyeball, and start with low gain and then move up to high gain, because what we'll see is that different things pop up on low versus high gain. So really, there's just 4 things you're looking for. 4 things. One of them is actually normal. You're hoping it's normal. But the 3 abnormal findings could be retinal detachment, vitreous hemorrhage, or a posterior vitreous detachment. So remember, this is painless vision loss or flashes of floaters to one eye only. So the first one is a retinal detachment. Ron, I think, what do you call it? You call it a snake or something popping its head up, or
like an eel coming out of the ocean bottom. Yeah,
exactly. It's something from the deep nether worlds in the back of the eye, and it's tethered back there, and it's coming up. So if you see that, if you see some tubular structure almost kind of coming with the back of the eye, you know it's probably the retina. And the other thing too, it's on low gain. So we'll see with the other 2 on high gain, you'll see them better, but on low gain, this retina should be seen. That kind of points it towards a retina versus like a vitreous detachment. And it's often tethered to that back of the eye. So here's a shot of kind of a retinal detachment. And what you see is it's tethered to that back of the eye. Now, granted, the gain's all turned up here, but at the same time, it's just certainly a retina, right? It's tethered to the back, it's hyperechoic. And just here's another shot of kind of another one. These are not subtle, okay? When someone comes with vision loss, painless, and you put that on, you see that. It's not subtle typically. And it can really aid towards calling your eye specialist and making a diagnosis really fast. So retinal detachment. Okay, vitreous hemorrhage. It's less of an emergency, but it's a great pickup too, and it rules out instead of a retinal detachment. This is sort of a snow globe sign or a washing machine sign. So you turn that gain up, and then you see this kind of echogenic stuff just kind of the back, just kind of moving around. So here's kind of that snow globe effect. This is just a vitreous hemorrhage.
So
Snow
Brian,
globe.
during your exam, are you just kind of playing with the gain all the time before you have a
Excellent
diagnosis?
point. Excellent point. What I'd probably do is start low gain, have a process, start low gain, have them look straight ahead. And I say, look to your left. Then I say, look to your right on low gain. And then I go, look straight ahead again. Then I have them look up and look down. And then I crank that gain up and have them do the same process.
Okay.
And if there's any question, you can rotate that probe 90 degrees and then go kind of sagittal instead of transverse. If you're really you don't see anything, you really want to comb that entire globe. So that's the process. Yeah. Excellent question. Last one, posterior vitreous detachment. So this is sort of, once again, high gain. It's where that whole vitreous is just pulled up off the back of the eye. And it's sort of like this, they call it a mobile swaying seaweed sign. You know how the retina is kind of tied to that optic nerve? This is just all lifted off. So it's not tethered to the back of the eye really. And it's oftentimes seen on high gain. So kind of this is like a posterior vitreous detachment. So you see how it's kind of like from one view, you think it could be the retina, but when you're looking at it straight on, it's just all pulled up basically, kind of ripped off the back of the eye. So that's that sort of a posterior vitreous detachment. All right, that's the eye.
Awesome.
We're moving
Love
on.
it. Okay. On to appendicitis. This is one of my favorite scans, and it's different depending on where you practice. If you're in a busy place or a rural place, like in a urban tertiary care center or rural, it's helpful for everyone. We all know the patient who we're going to scan and why we're doing it. So we're trying to avoid radiation from CT scans. Although, like I've talked about Dr. Johnson, now that I moved up north, CTing children north of the border is like forbidden basically, but we used to seem to do it all the time in the US. So I'm not really sure how that applies anymore.
We're still doing it. We're still doing it.
Right.
And it's
somehow if you show up with abdominal pain after 5 o'clock, you get a CT scan, but before 5 o'clock, you get an ultrasound. So anyway, that was the practice pattern I remember when I used to work mostly in the States. But really the Appy scan is a risk stratification scan. And it's really going to help out everybody's workflow depending on where you are. But the key caveat is choosing your patient. So it really works best in skinny or tiny people. So low BMI or a child or skinny child is really where we're going to go. And I'm really just talking linear probe here. There is a whole world where you can use a curvilinear, deeper penetration. But we're talking, we're emergency physicians. Like we don't have time. I don't have patience. I need answers quickly, and I have a very short attention span. So I really just stick to scans I can do with the linear for appendicitis, and that's it. And what you're looking for are two kind of groups of findings. The primary signs of appendicitis, which rules in appendicitis, finding a blind-ended, tubular, non-compressible structure. The books say 8 millimeters, but I can't remember numbers like that. So I round everything in POCUS up to a centimeter, because at least I'm not going to miss them if I round it up. And then if you're lucky, you see an appendicolith. The secondary signs of appendicitis, which are not, direct, but they're very suggestive of appendicitis. If you're used to seeing radiology reports, they say, appendix not visualized, but no secondary signs of appendicitis were seen. So that's kind of, you're looking for what they call the ring of fire, which is a Doppler light up around the appendix because you couldn't really identify it. They call it the thyroid of the belly, which is a bunch of gray fat stranding that also has increased Doppler signal. Where you're not supposed to see anything like that down there, or you see free fluid in the area of interest. And how to use this scan is really important to hammer home, because this is a point of care scan. So this is not a radiology performed ultrasound for appendicitis. The radiology texts or online resources talk about spending 15 minutes, like expect to spend at least 15 minutes finding an appendix. And finding a normal appendix is sort of, Jedi level ultrasound. Like if you're a point of care user, it's like the fellowship level training is to find the normal appendix. I don't really think if you're starting, you should have that as your goal. Your goal is to rule in obvious appendicitis with the primary signs. Maybe you start to rule out in a lower risk patient by not finding any secondary signs, and that's the game right there. So you have to use your clinical judgment. Like if you still think the patient has appendicitis, they're so tender, you're not finding it, you still need to do what you think, and don't just send them home or, searching for the normal appendix. And because you'll probably make mistakes early on, and you might call the wrong thing a normal appendix. And we don't want anyone causing any harm by introducing point of care into their workflows. Like I said, we're really focusing on the linear transducer, and there's kind of two ways I think to do this scan. The one that I prefer is what I call the sonographic McBurney's. I hand the probe to the patient and I say, push where it hurts. That way they're causing themselves pain. It's not me. So it's not on me that I like pushed really hard right where it hurt. And then also you'll be amazed when you hand it to them and they find the point for you. Even kids who are verbal and able to interact with you, you know, the appendix will often just show up on the screen. And then you're kind of done. You kind of take over from there and you make the image look a little prettier. And then you found your appendicitis. The other more, you know, sophisticated formal way, which if you don't find it on the sonographic McBurney's version, is you have to scan the whole colon. So you go from the umbilicus out lateral, you find what they call the dirty shadowing of the colon, and then you follow it down into the pelvis, where the colon essentially will disappear. And that's, you know, you found the cecum where you enter the pelvis. And your signs of that, which I'm about to show you, are the psoas muscle and the iliac artery. And once you're there, you start hunting for the appendix. The reason the hunt is so challenging, and I really call it off after 30 seconds, is because the appendix has all these different choices of where it can live. And it's really frustrating. You know, so the easy ones are the pre-ileal ones, the ones that come right up in front. You're going to drop your ultrasound right on those. And maybe you'll see the normal appendix, but it can also kind of go retrocecal, subcecal, post-ileal, pelvic. So all of those are going to be way harder to identify the normal appendix. And it's, you know, for a busy emergency physician, it's not worth my time. If it's 2 a.m. and I'm already awake and there's a kid and I want to spend 30 minutes and try and find it, you know, power to you. I'm not going to stop you. But just see it as a word of caution. So this is what it looks like to do the scan. So this is, again, using a linear probe, and you can see how deep down into the pelvis we are. We basically already found the colon, the cecum, and we've moved into the pelvis. And what we're highlighting on the screen here is the psoas muscle and the iliac artery. So there's no more abdominal contents anymore to really visualize here. And now we're gonna, from there, go back up. Look at how slowly the probe is moving back up into the abdomen, and boom. Dr. Tom Cook is able to find a normal appendix, but he is, you know, I would say Jedi level, like very advanced POCUS user. And there's the normal appendix. You can see that's like literally a couple millimeters thick, this tiny structure, and he was very patient to find it. And I'm going to chime in that he got super lucky on this patient. That's not a regular experience, would you say? So that his model happened to have a beautiful appendix. So again, you know, if there is appendicitis, you're going to have a different experience scanning that patient. And what that's going to look like, it's going to hurt when you push, and then you're going to find something like this. So this is a tubular structure. It's moving a little fast, but you can already identify it's not compressing. You're putting quite a bit of pressure on there, so all the gas is gone. There's some free fluid, and that structure, this one's a little bit short of a centimeter, right? Well, at least where that screen is frozen right there. But you can see something's up, right? You're finding something that certainly looks like an inflamed appendix without, and it's not compressing. So now you need to prove, is it blind-ended and tubular? It looks tubular, we've got that. The key is really proving that it's blind-ended, because you don't want to get tripped up by ileitis or, you know, an inflamed segment of bowel, right? So if we kind of skip ahead a little bit here, we'll see this is where the kind of length of that appendix goes down. And you can see that it really was blind-ended to, you have to follow it in longitudinal. So that's rotating the probe and seeing where it really terminates. This next one's going to be a much cleaner example of really finding that end. So as you're fanning through, there it is. You fan through and it just disappears. That's the blind end, right? So this is a dead end, inflamed appendix that needs a surgeon to take it out.
It's strikingly
Lastly is the
different
secondary
than
signs.
the normal one. Strikingly different than that normal one.
Agreed. Strikingly different. Yeah, like, you know, this is one of those scans where something shows up where you expect to see nothing, right? Usually you're looking in the abdomen and it's just a bunch of gas. So all of a sudden you see something. Like when you see something, oh, that's your clue. Maybe this is appendicitis. And like in this example, so here's another one. This patient's going to be in pain when you're scanning them and you're hunting. You're like, something's wrong. I see something. There's some free fluid here. There's some stuff. And then, okay, I'm going to put on my Doppler, and the Doppler, I'm going to pause it, shows you this ring of fire. Oh, there's my appendix right in the middle of the screen. And the reason I can't see it is because there's a big appendicolith in the middle obstructing my view. So it's like a gallstone look, like it's calcified, it's shadowing behind it, and it's super inflamed. This is kind of the thyroid of the belly look, all this gray tissue around it looks like a miniature thyroid gland in the abdomen, which you shouldn't be seeing at all. These are secondary signs of appendicitis. Brian, you want to say something?
Yeah, sorry. Well, speaking of like, you're just hunting for something abnormal. I thought a woman had a cholecystitis, and I was looking in the right upper quadrant, and we ended up finding like a retrocecal appy.
All the way in the right upper. I've had that. Yeah.
Yeah,
So
it's crazy.
I know. No one told you in medical school that the appendicitis can show up in the right upper quadrant.
Yeah.
Surprise. Yeah. Great.
Oh, it's my turn again.
Hand it back to
Okay.
you.
Thank you, sir. Okay. This one, I love this one. I think this is undervalued in the emergency department. When you can't get it access for someone, and pulling on an ultrasound and getting it in quickly is just awesome. The other thing that's great about this is that you can teach it as well. So like at my hospital, we rolled out a ton of like nursing driven ultrasound guided peripheral IVs. So it really takes the burden off of you. If you want to do it, no one else does. So teaching it, paying it forward, then you just start having these just team of people who can put ultrasound guided IVs in is just super powerful. Really what we're going to talk about is just sort of vein selection and success. Much like Iran mentioned with the appendicitis, like having them take the probe, I often ask the patient, I say, if you had this done before, and where do you go typically? And they'll point kind of the plumpiest vein under the skin that's great for ultrasound. And you really want to stay superficial. So that, high rate of success is superficial vein, linear, so it doesn't kind of like snake around. You want a large vein, you want it far from the artery and nerve, and not in a deep brachial space. And so what I do is I kind of scan up and down the arm. I start in the endocubital fossa, and then I sort of look along the volar aspect of the forearm. And then if I'm not seeing anything there, that's really my favorite spot to go. I'll kind of look up the lateral aspect of the upper arm, and then finally fall into sort of that medial upper arm or that deep brachial area. Deep brachial veins are okay. They're just deeper. They're hard to kind of get an IV in. And it got that they infiltrate. It's sort of in a deep space there, and it's hard for the patient to know it early on. So try to stay away from deep brachial if you can. And then really the sonographic differences of vein, artery, and nerve. I'll show you a video here, and then I think in the demo afterwards, we'll show, artery and nerve and vein. But a vein is easily compressible. It's a thin wall. It's not pulsatile. So that's what you want to hit. An artery is kind of the opposite. It's not easily compressible. It's got a thick wall, and it's pulsatile. If there's any concern, you can hit color and just see sort of color Doppler flow on the artery. And then nerves, those are things you want to stay away from as well, because the patient will certainly let you know very quickly. And so they're totally different. They're these honeycomb triangular structures, and kind of have anisotropy, meaning when you move the probe sort of back and forth, their brightness changes. So really identifying those three where you're going is important. This video just groups them all together. And so nerve is sort of screen left. That vein is a little smaller and thinner walled. And you can kind of see that artery is sort of pulsatile to the screen right. And so typically you wouldn't want to actually go for this vein. Maybe if this is the last chance you got, but you really don't want to, because bordering that vein is an artery and a nerve. So you really want to try to find something more isolated. And then this is the trenches. This is it. This is using the PAL in the ER, ultrasound guided IV.
I like the phone there. Yeah, like on the patient.
Yeah, that was I've been doing that too. If you have a compliant patient, I had one where it rolled off the bed, but if you're a pretty nice person, because it really gets your line of sight and view, because you don't want to be turning your head when you're doing these procedures. Right. You really want, with the earlier cart-based stuff, we'd put the machine on the other side of the patient. This kind of gets you even closer, just brings it right to the patient's chest, basically, or I'll put it on the side of the bed.
Maybe the other thing to point out also is that was a long IV catheter, right? Being inserted there, like pretty long.
Exactly. You want the longest 18 or 20 gauge IV you can, because you're going, under the skin, and so you're going to lose some of that length by just getting to the vein. And so I'll use either an 18 or 20 long angiocath, really to get it in. So that was a great job. Nice. In the trenches. And this is not the best image, but this is sort of like what it looks like sonographically. So this is a nice vein to go for, right? You can't really palpate it because it's just under the skin, but it's all alone there. You see, that's just all alone. And what you see is that tenting of the skin, And then you see this in transverse view, you see that needle tip just popping into the lumen. Slowly creep that IV in there, and you got yourself an ultrasound guided IV.
I like the use of the midline on that screen. That's a nice feature. You can, because you don't want to kind of slip off and move. And when you're getting it in, when you're doing these IVs, talk me through, like, you get the flash, right, in real life, IRL, but then you still see on the screen. Which one are you trusting more? Are you trusting your flash? Or are you trusting the needle in the vein on the screen?
IRL. I like it. I still follow the screen. I still follow the screen.
Yeah.
I'll get it. So I'll get it. It's all like you said. It's all Jedi. But if the vein is sort of staying superficial and linear, you drop that hand, and I kind of call it the creep method. You slowly move your probe. You slowly advance your needle tip, and you try to get as much of that angiocath in the lumen until you have sort of that leap of faith of threading it. So once I feel or see a flash, but I know sonographic I'm in, I'll just creep until I get more than half that angiocath in there. And then oftentimes, depends on how I'm holding, I'll drop the probe, or then I'll thread it with the probe still on. But I'm still just really looking at that screen to make sure I haven't back walled it, and I make sure I can get as much angiocath in as possible. Yeah, the creep
is following your needle tip, right? So just moving, probe, IV, probe, IV, probe,
exactly,
IV, right? Until you kind of see the tip and you like make the tip appear and disappear on your screen.
100%. Because if you're just keeping your probe stationary and moving your angiocath, you're losing your tip, because your needle tip's going past that probe. So you always want to be moving in concert, the probe and then the needle tip, the probe and the needle tip.
Yeah, I distinctly remember one of our attendings in residency putting in an inadvertent art line that way. Yes.
Yeah, it's well, it's sometimes, like I said, like that last image, if it's your last chance, if this is the only vein I got, this guy's sick, the gal's sick, I go for it. And if I hit the artery, it's sort of a risk I've come to a point I'd have to do, because I have to try to get something in somewhere and stuff like that. So, yeah. But it's better than going blind, So, okay. So there's that. Okay. SBO.
Okay, my turn. Okay. SBO. Why do this one? This is another super helpful ultrasound, no matter where you work. Again, I work mostly in busy urban centers, but I do a lot of work also in rural. Wherever I am, it's helpful because it's helping my workflow either way. Either I'm in a place where I can order a CT scan with a click, or I'm trying to convince somebody on the phone to take a patient who sometimes needs a significant travel time to get surgery, or even just to get the CT scan or some kind of definitive care. So either way, this ultrasound is super helpful. And the tagline for me on the SBO is to really never order an abdominal X-ray again. So if you grew up with the practice of risk stratifying your query SBO patients with an abdominal X-ray to look for loops, this is a test that outperforms it by orders of magnitude. And the data is like quite clear about that the abdominal X-ray, the sensitivity and specificity, your likelihood ratios to help your management are so poor. How many indeterminate bowel gas patterns do you get back from radiology or from you? And they're like, well, now what do I do? It didn't really help at all. So here's something that's going to help you a lot more in figuring out what's going on with your patients. And, I love that the radiologists are even behind this. Of like, why are we even bothering with these abdominal X-rays? These are radiologists who they're paid to read the X-rays. And stop sending us these. So, how do you do it? What I also love about the SBO is it's really technically probably the easiest scan, would you say, Brian? You basically just mow the abdomen. There's not much to it. You're really just kind of scanning the entire abdomen. The one thing is to make sure you don't just go in the front, that you check also the paracolic gutters. And the reason is, if people have a big bowel obstruction, there's all this gas stuck in these loops of bowel, and those are going to often float to the top while they're laying down. And so all you're seeing is the air. You're not seeing the findings that you need to, which I'll talk to you in a second about. So dropping in the body to the sagittal plane and really taking a look below all that gas helps you make sure that you're not missing some sign of bowel obstruction if you're just getting gassed out. And what that looks like is this. So here I am. This is I'm using the PAL, but on an abdomen preset, and I'm just mowing the abdomen up one quadrant, other quadrant, and then I'm going to just go back down on the other side, mow down, right? And this is what I expect to see, is just a bunch of bowel gas, a lot of shadowing stuff, sparkles, it's kind of indeterminate findings. This is what we're used to seeing on abdominal ultrasounds. And then this is the paracolic gutters, where you have to slide down into the sagittal plane, right? And then you just check. It's kind of right below your EFAS spot. So below the spleen and kidney on the left and below the liver and kidney on the right. I'm really trying this time to just get gassed out by abdomen. And what you're looking for that suggests a bowel obstruction is anything that's not gas. So again, the same way we were talking about the API scan, you're kind of expecting to see nothing, right? That's the normal. And the same thing with the bowel obstruction, you're just expecting to see lots of noise. With bowel obstructions, it's a similar experience. You put the probe on and boom, it just kind of jumps up out at you and you're like, oh, okay, that's a finding. And what you're gonna see is a constellation of these symptoms. Dilated fluid-filled loops. You might see wall thickening of the intestines. My favorite is the lack of peristalsis, or the poop moving back and forth. I've heard it called the poop waterfall effect. There's some other fun names for it, or free fluid in the abdomen. And the research is clear that the more of these findings you see, the higher the likelihood not only of them having a bowel obstruction, but also of them needing a surgery. With appendicitis, pretty much most APIs still go to surgery. There's this movement towards antibiotics, but if they have the diagnosis, it's a diagnosis. For bowel obstruction, most of these patients do not need surgery. But if you see all of these findings, especially if you're seeing free fluid, it can be suggestive, oh, this is a higher grade obstruction. This patient might actually become sicker and be one of those who actually needs to go for operation. The NG tube and bowel rest is not going to be enough. And so this is what it looks like. You pop on the probe and boom, something's there, right? It's not just gas. You're seeing here fluid-filled loops of bowel. There's even a trace of free fluid in between those loops there. And if you rotate into longitudinal, you'll start seeing that kind of lack of peristalsis. This one, you're still seeing stuff kind of move back and forth in the loop, but sometimes you can just see complete bowel just sitting there. So here's another example where you even see the, what did we call it again? The lines in the intestine.
Hofstra.
I'm outing myself. Hofstra, thanks.
Right?
We're seeing even right. You shouldn't be seeing that in a normal intestine. And down below, you can really see that kind of waterfall effect of poop. It's like swaying in the wind.
So satisfying to see for the provider. But the opposite
for the provider, maybe not for the patient. I know they're sad. Okay, here's another one, right? So you shouldn't see any loops of bowel, right? Like when you look in the bowel, you should see nothing. You definitely shouldn't be seeing a big fluid fill. This one has wall thickening because I can see the walls and all the kind of the contours of the walls. That's obviously abnormal. And one more, because I can kind of never get enough of the lack of peristalsis. It's very satisfying. Oh, I even snuck in one more because I just can't get enough. But it's really all a finding. What to do with the finding is something we can talk about maybe in the Q&A. This is kind of the same issue with the appendicitis scan of I have yet to meet doctors, and maybe some of you in the Q&A, I'd love to hear it, can get a patient to surgery on your ultrasound, right? So, that is really ultimately what they need, and we're not there yet. And so it's a similar thing with bowel obstruction. If I call the surgeon, this patient has a bowel obstruction, I think on my ultrasound, I usually get kind of either blank look and they're like, well, what did the CT show? That's often in the urban place, that's kind of what I get. I think in more rural communities where you have a different relationship with the surgeons, they may know your skills depending on where you're at with all of this practice, and it can change. And I will say, sometimes the surgeon needs the x-ray, right? So you can do the ultrasound, you're convinced they have a bowel obstruction, you saw all the findings, then you order the x-ray so that you can get the surgeon to come and see the patient because they don't know how to read ultrasound. That's not your fault, that's their fault, right? It's that they don't know how to read ultrasound. It's not your problem, but you have to kind of work together in the sandbox. One thing I will say though is we still need clinical judgment. You may see all these findings on the ultrasound and think, wow, this is definitely a bowel obstruction, but it may not be. So there's a continuum of symptoms from an ileus to, essentially ischemia. So patients who have a bad ileus, they may have fluid-filled loops of bowel that aren't moving very well. You shouldn't really see thickening of the bowels, and you shouldn't see free fluid, but you can see some of those early signs of bowel obstruction and confuse it. So it certainly puts them into a higher risk category, and you can't tell just from a couple ultrasound findings. Similarly, if it's ischemic bowel, it's also bowel that's not working. So if they had an embolic event, or I had a patient recently who was hypoperfused in septic shock, we were convinced it was a ischemic bowel obstruction and that they had just twisted and it was dying bowel from that. But it really was they were just in such shocky state that their bowels weren't getting any flow anymore, and that can also look like an obstruction. So as that lactate's going up and they're sick, either way, they need a surgeon probably, whether it's an obstruction or ischemia, someone needs to run the bowels. So you still need to use your clinical judgment and figure it out there. And as a final example, this is, a patient where you throw the ultrasound on, you're finding things like here are some loops of bowel. They're really thickened, as you can tell, like they look quite abnormal. Yeah. These are loops of intestine. They're very thick and fluid filled. And then you get this longitudinal view we were just looking at, thick wall, not much happening there in terms of peristalsis, but this is the patient in septic shock and it's not a primary obstruction. So, you just remember, gotta keep that broad clinical lens. This is a clue into their presentation, but it may not seal the deal, but they still needed a laparotomy either way. There we go. It's all you.
Thank you once again. All right, this is the last one. This is the last useful POCUS for your next shift. We've gone from the eye to the belly, to the vein, to the belly, and now to the groin, where every ER doctor is very well versed. We know that inguinal area very well. Central line.
Is that a professional comment or a personal comment?
No comments, but comments. Professional. Always professional. We're always professional here. Good. Yes. So, okay. The femoral or fascial iliaca block, infrainguinal, we're going to talk about infrainguinal. So the indications really are hip and femur fractures. But you can also do this for like a proximal tib fracture or a near patellar injury or like an abscess or lac to the anterior thigh. And then anytime we talk about blocks, we talk about when not to do them. So if they can't provide consent, if they're demented, or they're just like, I don't want a needle in that area, which happens to me all the time when I ask them, surprisingly. If there's any neurovascular compromise, if there's any concern for compartment syndrome, super low risk for compartment syndrome of the thigh, but if there's any concern, or if they're anticoagulated, you can't block them. You need a lot of stuff actually to do a block. So you definitely need your ultrasound and then some 1% Lido to kind of numb the skin. And then based upon your shop sort of chlorhexidine scrub, sterile gloves, ultrasound probe cover, or a clear adhesive dressing, the block agent of choice is ropivacaine. We want a really long acting block, like 20 to 30 cc's of ropivacaine. And then you need a block needle. You need a kind of longer, blunt tipped. I use, and I think Oron uses too, Pajunk needles, but any other blunt tip device. If you need IV tubing, the beauty of these needles here is that the tubing is already attached. So your assistant can actually inject the saline and then the ropivacaine. If you don't, you can just use a control syringe. And then once again, anytime we talk about blocks, they need to be on a monitor, airway supplies, God forbid, and pulse ox, and know where your intralipid is in the department. Very low risk for, local anesthetic, systemic toxicity, but we should always know where that stuff is. Okay, brief anatomy. Really what you're blocking is the femoral nerve, but because of the volume and where you're going under the fascial iliaca, you're hopefully pushing back up to kind of hit the obturator nerve and getting the lateral femoral cutaneous nerve, because the hip is, complexly innervated. And so for a femur fracture, this block's going to work really good. For hip fracture, it's not going to be the end all be all, but it's going to give you quite a bit of relief. I don't know, Warren, you can mention like systemic opioids, old people, they're just like still kind of in pain, moaning, or they're sedated. They're not sleeping. My thing is always like, once I block them, I go ask them how they're doing, and they're like, they're sleeping. So I'm always like, okay, that's kind of my go all, that I know I got it down enough to kind of give them some relief for the night usually. So.
And I mean, it depends what you're blocking. Patients with I had not that long ago, a patient with a femur fracture who required, so much opiates in the field and getting in, transferring, was super loaded up. We did the block pretty quick because we had to pull them out into extension and splint them. And as soon as I put the block in, like within 5 minutes, he almost went apneic because, he finally relaxed, and then all those opioids like suddenly took away his respiratory. He lost all his fight. All the fight against it was gone. And it's like, oh, sit him up, oxygen, like what happened? Narcan almost. We had the Narcan ready to go. So it was a thing.
Yeah. So these they're great. They give you some relief. Oh yeah, so this is just this kind of gross anatomy. Is you're really going under that inguinal ligament with your probe, and really sort of you're kind of looking for that femoral nerve, which is lateral to the femoral artery and femoral vein. And I'll show you through an ultrasound photo here. That once again, we sort of talk about what arteries and veins and nerves look like. Well, this is a big nerve. This is way bigger than one you'd see for a peripheral IV. So it's this nice, beautiful honeycomb structure lateral to the femoral artery. And we'll show you a video soon, but you're really taking that needle and coming way over here, popping under that fascia iliaca and dumping a bunch of anesthetic way over here. The reason ultrasound is so great is that it stays so far away. You don't accidentally hit the artery. You're not going into the nerve because you know exactly where it is. Okay, so here it is.
Another in the trenches.
This is in the trenches. So what's going on first? This is that local anesthetic. Some people just say make a wheel, but I put a bunch around there, to be honest, because the person, they broke their hip or their femur, or you're doing something already. So why not put more anesthetic around? So you put anesthetic, and then you get your nerve block needle, and you have your sort of, this is going to be a linear probe, and you have sort of your visualization fairly close to you, so you're not sort of looking away and trying to block. You're kind of in the same vision. And so these sort of block needles, they're actually hard to get through the skin sometimes. You have to kind of pop through. And then what you're seeing here is, and you'll have a kind of a double pop because you pop through the skin, but then you're going to pop through that underneath that fascia iliaca.
One
So
thing,
there's your needle
when I do these blocks, I always use saline. So I have an assistant. I have a nurse or a medical assistant with helping me who's doing my injecting. Thankfully, if I have an extra set of hands, but because I don't want to waste that precious anesthetic, like you were saying, and I want to make sure I get all the volume where I want it to be, I start with sterile saline in the initial like dissection with the block needle until I get to the right plane. And then I ask them, okay, switch to the syringe with the anesthetic. And so I didn't waste any of my anesthetic getting down to where I want to go.
Totally agree. Like with saline, there's no harm, basically. You're not, aside from the actual, but this is a blunt needle, right? So you're not like cutting the nerve. And then, if you're using just saline, there's no intraneural injection concern. God forbid you don't know where you are and you're near a vein or artery, you just have normal saline. It's really safe. And it opens up like you see there. Then once you get nicely opened up there, then you can then put your anesthetic in because you have this big window to just sort of kind of bathe that nerve. Now we're going to go to, there it is. Okay, now we're going sonographically. So here's that same block. You're seeing the femoral artery. Here it comes. Okay, there we go. Okay, watch this. Okay, so he's a little on top.
Not in yet.
He or she's a little on top. Putting a little there. So this is your needle right there in plane. Nerve over here, right? Waiting.
And
still too
one
high.
Trick,
still
Brian,
too high.
One trick while you're finding the fascial plane, right, is to use saline instead of wasting that anesthetic. Oh, that's satisfying right there.
That's always satisfying. Whenever for ultrasound people, when you're watching these or doing it, when you see it, you're like it's like seeing poop in the intestines. So you're under that fascia iliaca, and now you know, okay, everything's gravy now. So you're under that, the nerve is over here, the artery is even out of screen. And this is when you really just hydrodissect, inject 3 to 5 cc's. You know, whoever's pushing that anesthetic, just make sure there's no pressure with it. And you're just really bathing that nerve to get a really good block. And I'll just kind of speed up here a little bit. So basically, see that? Now we see the artery, vein, artery, nerve, and then the needle right there. So basically, you're just going to keep bathing that. All right, that's our fem block.
Great. Such a pretty image. Excellent. Well, thank you both for your insights. And I'm going to just hand things over to Janae. She's going to give us a live demo using the PAL. And so Janae, we'll hand it to you.
Thanks, Shelley. And thank you, Dr. Frenkel and Dr. Johnson, for all of that great information. For my demo today, I am going to be using the Clarus PAL transducer. And for those of you who haven't had a chance to have a look at the dual array, here it is here. You can see on this side of the scanner, that's the phased array portion. And over here on this side, that would be the linear array. portion. And one of the things that makes this scanner so efficient is that it is very easy to switch between the phased and linear array. And we can do that in one of two ways. We can pre-program the button here that's right on the scanner itself, or we can switch the preset on the app, and that'll switch between the two arrays quite easily. And today I'm going to demonstrate how some of the features of the PAL transducer can aid in IV insertions. So I'll start by selecting the vascular preset here on the app. There it is. And I'm also going to turn on the voice controls so that I can switch my imaging presets here without actually having to touch the screen. That's really helpful when we're doing things like IV insertions. So let's start by, we'll start down here at the antecubital fossa. And let's increase our depth. And I'm just gonna, just bring your arm over a little bit closer here, sorry. And I'm going to find that decrease depth, decrease depth, decrease depth. And right here, I have located the basilic vein in the upper arm. And so we're looking at some of those. Oh yes, it is. And it's nice and compressible, thin walled, all of those things that we talked about. And so the scanner has a center line that correlates with the center of the image. So I'm going to center this in our image here. And I'm going to turn on the center guide. So the center guide provides this nice clean line through the center of our image. And it correlates with the center line on the scanner itself. And this will indicate where we'll want to insert a needle for an out of plane approach for the IV. There we go. Basilic vein. All right, and let's have a look up here. Let's go up to the jugular vein. I'm going to put a little bit more gel on my scanner. And I'm going to use the voice controls to adjust the depth and gain as needed since we're on a different body part here. So increase depth. Come over here. And our model here has a nice juicy jugular vein. Woo. And it looks great. And so in this case, we'll be using the center line on the other side of the scanner. I'll center this here a little bit better. And we will, and we're going to line up the needle access, and we're going to access the vein in plane from a lateral approach this time for the jugular vein. So as you can see, these features make it a lot easier to access the veins with the scanner. And since we have some time, let's have a quick look at the new EFAS preset. I'll head over here. So the EFAS preset was developed to speed up this exam while at the same time optimizing our image. So we're going to start, again, using the PAL scanner. We're going to start at Morrison's pouch over here in that right upper quadrant. And we're going to go ahead and select the abdominal icon here at the bottom of the screen. And you can see we have a beautiful picture of Morrison's pouch. And so the image has been optimized to look for free fluid. Here we can also see the inferior edge of the liver. And if we increase our depth here, we can see the upper dome of the liver and also the diaphragm. And then to quickly switch over, if we want to do some cardiac scanning, I can simply select the heart image there on the bottom of the screen, and the image is optimized with a beautiful view of the heart. Nice and strong. So that was good. And then if we want to switch over and have a quick look at the lungs, and increase the depth a little bit here. So when we select the lung icon on the bottom of the screen here, the image is optimized for deep lung scanning. And then to switch over, if we want to have a look at the pleura, we can simply select the shallow lung preset on the app, and we get a nice view of the lung pleura there. So there's two ways that we can switch. It's gone from the phased array to the linear array just at the touch of a button, but we can also pre-program the button on the scanner, and just a double click would switch the arrays from phased to linear. And the other great thing about the eFast preset is that when we head over to the patient demographics page, and we scroll down, there's quite a few areas here that we can populate for indications, captures, impressions, findings, interpretations, and quality assurance scoring to meet your ACEP indications. And that's how versatile the Clarus PAL scanner is. I'm going to hand it back to you, Shelley.
That's great, Janae. Thank you so much. Great demo. Always exciting to see the new PAL in action. Now, before we open the floor to questions, and we may go over a little bit here, I'd like to invite you all to take just a little poll to let us know if we can provide further information about Clarus wireless ultrasound, whether it be the new PAL or any of our phased convex or linear array scanners. So click on as many as apply here. And while you're completing a poll, I'd like to share a little more about the new Clarus PAL HD3 dual away wireless scanner for whole body ultrasound. It's approved by FDA and, like I said, available now for sale in the EU and Australia. And as you saw during the presentation, and when Janae was scanning, the PAL has an innovative dual array design that delivers unsurpassed fertility and amazing image quality for both superficial and deep abdominal or cardiac imaging. Frequency range is 1 to 15 megahertz with a quick transition, for example, from cardiac to shallow lung. And clinicians say that they can perform 95 to 99% of bedside exams with a single scanner, eliminating the need to swap probes and reducing interruptions, improving workflow continuity. Clarus scanners are powered by AI and deliver up to 8 times the processing power and the frame rates of other handhelds. You get the performance and image quality of more traditional ultrasound systems, but in a small portable device for a mere fraction of the cost. Our scanners are IP67 rated, waterproof, and fully submersible for rapid disinfection, and include a complete ecosystem that includes an easy-to-use app for your iOS or Android device and for unlimited users. And for exam management, membership provides exam management in the form of Clarus Cloud, or you can save images to a local PAC server through the current DICOM web standard. And available with membership as well, the Advanced Primary and Critical Care Package offers additional AI tools, specialized presets, and automated workflows for common generalized scanning for fast, eFast, and whole body imaging. So we'll give you just another minute to complete the poll while we watch this fun Clarus PAL launch video.
Chosen one, I can get it done. Zip, bang, boom, pow, every mission one. Got that laser vision, cause I'm born a legend. Get up, get up, get up, let's roll. Ooh, I'm a drive-through thriller. Ooh, no one else does it better. Watch me, watch me, watch me, let's go. I'm stronger than you've ever seen. I got superpower. Let's go. I got superpower.
Great. All right. Well, we have a ton of questions. Dr. Frenkel and Dr. Johnson, I'm going to hand it over to you to try and plow through as many as you can.
Sure. Yeah, let's do it. Let's see. One thing I want to address is kind of came up in a couple questions in terms of risk management. I don't know how you use it, Brian, but for appendicitis, like I said, I don't know any case where people are convincing the surgeons to take people to the OR based on their POCUS scans. So, the way when I work in a busy urban center, I use the ultrasound as if I see the appendicitis in my 30 to 45 second scan, I will get them a radiology performed ultrasound because I know if I can see it, the technologist can see it. If I don't see it, then they're usually going to CT. When I'm working rural, it's different. At least it helps me kind of risk stratify. If I don't see any signs of appendicitis, it's a healthy looking kid, or if I'm, here in the city and the kid looks good and I don't think it's appendicitis, I even thought maybe I should just take a look. I don't see any secondary signs. It's usually a 12-hour recheck, right? If they have vomiting, abdominal pain, the diarrhea hasn't come yet, says come back in 12 hours. If the pain is still there, we'll recheck you. But it's sort of reassuring, like I don't need to keep the kid overnight for observation or anything like that. That's kind of how I use it.
100%. I never anchor, to be honest, on my emergency, my point of care ultrasound, because it's not comprehensive. It's limited. It's to help me. It's not to hurt me whatsoever.
Right.
I will always back it up with something else if I have any concern. 100%. Yeah.
What do you say to this, Brian? What's the best alternative if you don't have block needles? I feel like we grew up using spinal needles for blocks.
Yeah, that's all I did. That's all I did with
Yeah.
spinal needles, to be honest. Cutting, like, 3.5-inch spinal needles.
Ew. Yeah.
I was doing I was doing a control syringe with a spinal needle. And the problem with those control syringes, they only used 10 cc's basically. So I was filling up a bunch of them, and then I would just stabilize and reattach and go. It's come a long way. I mean, regional anesthesia was bred into kind of anesthesia. And so we've really adopted a lot of their practices to be just better block agents in the ED. So definitely there's like a TUI sort of syringes or needles. There's all sorts of different type of Quinky needles as well. If you, whatever shop you're asking, if you can ask your nurse manager or whoever staffs, like what type of needles they have, be it blunt or not blunt, and kind of figure it out from there. But there's a lot of companies that make a lot of really good block needles though too. So
yeah, I mean, the advantage of the block needle is like you're not going to slice. If you do get too close to the nerve, your chance of intraneural injection is lower, right? It's not going to slice into a vessel as easily. And it's very echogenic, so you see it really nicely, even if you're just a bit off axis in the ultrasound.
Yeah, with the ultrasound settings of like nerve block with the highly echogenic needle, it's really better than what we used to do in residency. It's really nice.
Definitely.
Really seeing that tip it just built so much more confidence. Really, we always teach seeing that tip, seeing where that tip is at all times is so important. And they're really,
that's the whole reason you're doing it.
Yeah,
it's the whole reason you're doing it with ultrasound.
Exactly.
I will also address, since we're on kind of a gear questions, this comes up a lot, and there's a bunch of them about this of the sterility around IV placement or the block. Those in the trenches videos showed, what I a similar theme of what I refer to as like the dirty sterile, right? Like I imagine the skin was prepped ahead of time for those videos. I could see the pink Chlorhex, sterile gel, and then adhesive dressing, right? A sterile adhesive dressing over the probe.
Yeah, I kind of agree. I mean, it all also depends on your shop too, and like guidelines and getting buy-in and everything. Don't do any of those procedures, really blocks, and even peripheral ultrasound guided peripheral IVs without having some buy-in. I mean, when we initially rolled out our ultrasound guided stuff, there was some concerns on the floor that we were not documenting them, or we're putting them in places that could obscure PIC lines or midlines in the future. Those have sort of all gone away because they realize how useful we are with putting ultrasound guided IVs. So yeah, if the really sterility things really I will use a Tegaderm and then a clear or like a single use gel oftentimes. If there's any concern, like it's just a higher risk for infection type patient, you can always put on like a probe cover for that ultrasound.
I agree.
Yeah.
It's there's always room to kind of up sterile it. Right?
You
can go full sterile with the drape and the probe cover. But my take, I guess, is when we watch our nurses put in, like those IVs going in are not that clean, right? They're like licking their finger to feel the vein. Like, it's there's a lot of stuff happening there that's not sterile at all. So this is a one-up. Like there's nothing, your bacterial load into the skin is not that significant from doing it. So
yeah.
We're running out of time. Let's try and squeeze in a couple more here. Do you use it? This is a good one. I felt like I was ready to finish my fellowship when I could place an IV on a chubby toddler with the ultrasound. Do you kind of recommend, like, do you have any kind of takes on where do you put the IV in on the chubby toddler?
Oh, geez.
The 1-year-old.
I mean,
it's specifically the 1-year-old, I think, is like, that's when it's like, all bets are off. No one can feel, even your best peds nurses can't feel a vein anymore. It's like, they're they're like the BMI equivalent of a 50 on an adult or something.
Putting my hands like this, I'm like, yeah, that's exactly the one where they come to me an hour later going, we haven't gotten anything. And I'm like, you know, it really is. I had the same sort of like, especially that kid's going to have veins. They're going to be really tiny. So you're going to be putting a 22 or something, 24 in it. But I kind of do the same thing. I'll kind of look AC forearm and then right upper arm kind of thing. Those are really hard. Those are really hard. But just do the same. Just take it slow. Don't put too much pressure when you're scanning because they're so tiny. And you're nervous too, so you're pushing a little hard and you can obscure those small little veins that are just sort of like just that you're pushing down. So really have a gentle touch. Make sure you have someone to help and stabilize that arm really well. And then just sort of like, and typically it's going to be a really superficial poke too. You're not going to go deep at all. So you're going to have to really superficial approach to. So just to optimize your success with positioning. Yeah.
I want to squeeze one more in. Do you ever do longitudinal view when you, like, we did it for the block. Do you ever do it for IVs or any access?
I never do, but I teach it that way. You certainly can do it. It's prettier. It's way prettier that way. But just me in terms of, I just am not very good at it because it's so much cleaner for me in a transverse view. It's so much easier. It's just the way I trained. I've never seen anyone come across who regularly does a longitudinal ultrasound guided peripheral IV. I've never met anybody who really does it. But you can always, like, there's those cases where you're like, am I in the back wall? So when you're on it, just flip it 90 degrees and you can see if your needle's kind of hitting the back wall of the IV or the vein. But I really, really don't do it unless you're just kind of showing off a little bit, typically.
Yeah, I agree. It's a show off move.
It is pretty.
It's pretty. It's way pretty though. It's way pretty.
Yeah. All right.
Great. Maybe we should respect people's time and we'll call it.
Sure. Yeah. All right. Well, thank you everyone for your questions. We had dozens and dozens of them. And if we didn't get to your question or you asked for more information in the poll, we'll follow up with a email in the coming week and you'll receive a PDF copy of the slides and a webinar recording as well. So keep an eye on your inbox. Thank you, Dr. Frenkel and Dr. Johnson. It was a great presentation. And of course, a very big thank you to all of you for joining us. And I encourage you all to complete our closing survey just to provide feedback so we can continue to bring you more educational events like today's. So until our next event, take care, keep scanning. Bye now.
Bye, everyone. Thanks.
Bye.